Good morning, I'm Markos Valsamis, I'm an orthopedic registrar in Oxford, and I'll be talking to you about the reverse versus the anatomical total shoulder replacement for osteoarthritis. So how can I change the slide?
It should advance. You just. Oh, sorry, I've taken.
Oh, sorry.
Small error.
Okay. So the reverse total shoulder replacement was originally designed to be used in patients without an intact rotator cuff. And since its introduction in the UK in around 2008, as you can see from the blue line in the graph on the right, its use has exploded in popularity. This is now being used not only for patients without an intact rotator cuff, but across different surgical indications, including for patients with osteoarthritis and an intact rotator cuff who would otherwise normally be having an anatomical total shoulder replacement. This is despite any good evidence to support this, and therefore our study was aimed to examine the clinical effectiveness as well as the economic implications of using a reverse over an anatomical total shoulder replacement in patients aged 60 years and older with osteoarthritis and an intact rotator cuff. We used linked data from the National Joint Registry and NHS hospital episode statistics from 2012 to 2020. Our eligibility criteria were that group I described, and our primary clinical outcome was revision surgery at any time point, and secondary outcomes included reoperations that were not defined as revisions within a year of surgery, serious adverse events within 90 days that included medical complications requiring admission to hospital, and prolonged hospital stay. From a cost perspective, we were interested in inpatient costs incurred during hospital stays for primary and revision surgeries, as well as for any medical complications or reoperations. We generated propensity scores based on a number of confounding factors to allow similar comparison between the groups, and we used two methodologies: propensity score matching as well as inverse probability of treatment weighting. For revision surgery, we developed flexible parametric survival models, and for our binary outcomes of interest, we used logistic regression models. For our cost analysis, we used a lifetime Markov model where patients would transition between unrevised, revised, and dead states over time, and use probabilistic sensitivity analysis to capture any uncertainty in that modeling process. For both the propensity score matching and the weighting methodologies, we found relatively similar results. You can see that the survival curves for each of these, for the reverse and the anatomical total shoulder replacement, were broadly similar. And in the second row, you can see that the hazard ratio of the risk of revision for the reverse was significantly lower for the first to third year after surgery. But this did not amount to a very important absolute risk difference, and this is shown in the final row at the bottom. And what that graph shows is the difference in the areas under the curves over time, under the curves of the first row, called difference in the restricted mean survival time. And what that showed is that ultimately the reverse total shoulder replacement had approximately 20 days difference of revision-free survival by almost 9 years. So 20 days at around 9 years is not very important. For our secondary outcomes, there was no statistically significant difference for any of them with any methodologies, apart from for reoperations when using matching. That showed that the reverse had half the risk of a reoperation within a year after surgery compared to the anatomical total shoulder replacement, but the absolute risk difference was just 0.5%. So again, that's clinically not drastically different. For our cost analysis, for both the base case analysis and certain sensitivity analysis we undertook, there was no significant difference. In terms of the limitations of this study, the main limitation, in my opinion, was the fact that we didn't have any record of the glenoid characteristics to adjust for as a confounding variable. Now this has since been added in the most recent MDS forms for the NJR, but for our data we didn't have this information. It's also possible that rotator cuffs fail at a time point after 9 years, and that would then, for example, show a significant increase in anatomical total shoulder replacements being revised to reverse, but up until 9 years there was no big difference, as you saw. In terms of prompts, we did undertake an analysis, which I didn't show, but we found that there was no significant difference in the improvement of prompts from preoperative to postoperative. The reason I'm putting this as a limitation is only 10% of all procedures had a non-missing paired preoperative and postoperative prompt, so this does need to be taken with a pinch of salt. What we can conclude, however, is that the reverse is a safe and acceptable alternative to the anatomical total shoulder replacement in this patient group. But we do need randomized controlled trial results to fully evaluate cost effectiveness, and we do need some more information, more robust information on patient-reported outcome measures. And the Rhapsody trial that's currently recruiting across the UK and Australia will hopefully help to provide more information about this. I'd like to thank the National Joint Registry for providing the data used in this work, the NHR for funding my research, and the University of Oxford for supporting my work. If you'd like to find out more about the study, you can read our paper that was published last year. Thanks very much.